Professor Wu, you've at the Rose Foundation, you've carried out self-sampling for about 20 over 1,000 women in the country. What has been the positive rate of detection amongst this population that you have screened? How many percentage actually have come out with precancerous lesions or who need treatment?
Okay, so there are a few things we need to clarify. So if you have a positive detection, what you call a positive screening test, that does not translate to a precancer. So in the Malaysian setting, if we screen 100 women, we will find that 6 will have HPV, high-risk HPV detected in the swab. So 6 in 100, but that does not mean 6 in 100 have cancer. So that's quite important in our communication, and that's an overall number, and we have areas where it's 12 in 100 and areas where it's 2 in 100, so depending on the population. So Malaysia is fortunate in the sense that it's not that high, and therefore we are able to we have the workforce, we have the facility to manage and to treat these, to review these 6 patients or 6 women, to then offer them whatever treatment is necessary. So I would say in our 25,000 screens, we've only detected about 4 to 5 advanced cancers where they've been led to care and they are survivors now. But we've managed to detect 600 to 700, if not more, pre-cancer changes that we've treated successfully.
Fantastic. And have the women been confident about taking their own samples? I mean, are they okay to insert the swab themselves? Are they confident enough?
Not all. I think to say that everyone smiles and they're happy doing this, it will be a lie. I as a Malaysian or Malaysian population, we don't even use tampons. We're not comfortable with our own female anatomy. We don't understand that anatomy, and so to insert an instrument yourself will require a significant amount of education, pictorially, verbally, even through media, to teach them about their own anatomy and how to take a swab without hurting themselves. Of course, compared to a pap smear, this is way more acceptable. We have asked women, how do you feel about this? 99%, I don't know what happened to that one woman, but 99% of them will say, I will have a swab anytime compared to a speculum examination. So even in a conservative community, when we go to the kampongs where they don't usually access healthcare, a swab is very acceptable, and they can do it if you spend some time teaching them how to do it.
Are there barriers to that? Cultural barriers?
Yes. It's with everything in healthcare. Our health-seeking behaviors are very different in the urban and in the rural setting. Many rural individuals wouldn't have seen any doctors in their lifetime. Even the babies are had at home, right? So to convince them when they are well, to say, have this test done, where they have doubts of, that will prevent you from getting sick, that is a major barrier, major barrier to change health-seeking behavior. To say that we can do something that will not incur cost to you in our program. And of course, I say this because many people fear having a test done, because when they have the test done, the unknown of going to the hospital, the financial implications are great, and that's out of their control. So to be able to control that narrative, to tell them what the end point is, to communicate that correctly is extremely important. It's critical.
We need an army of healthcare professionals who can actually convey this narrative. Do you think that's going to take a long time?
No, we can and we must do that. even if it's not a perfect message, initially we have to get started compared to not having anything done at all. One of the things is the unknown, and we talk about stigma and fear. We have had data to show that when someone has an abnormal screening test, 87% of them already think they have cancer. They think they have cancer. Imagine that fear, the anxiety. And they stop having any relationship with their husbands until they are seen. But what our data shows that as soon as they've seen a healthcare professional, the stress level and everything goes down to nothing, and the sense of well-being goes up to 90%. They then say that, I feel good that I've done something about that. So we have data to show that. So what this tells us is that we really have a lot of work to do. We need to communicate that information and deal with the anxiety and unknown more effectively. So the vaccines, the swabs, that's all sorted out. I think it's how to reach and how to deliver that message.
And I want to say that in my career, self-collection has been the biggest breakthrough in cervical cancer prevention. And whilst it's not perfect and it doesn't overcome all of the barriers, it overcomes so many and makes such a big difference that we've got to screen the people who need it, who are willing to be screened. We've got to keep working on what Yinling's talking about some of the other barriers. But you know, some of the barriers are cultural and are overcome through bodily autonomy, through the patient being able to take the sample themselves rather than have another person in that part of their anatomy. So I think one of the things we do is we always want to improve what we're doing, and we focus on what's not working, and it's important that we do that because that's how things will get better. But we were talking about this morning. We've really got to put this in the context of how big a breakthrough this is. Breakthroughs aren't perfect, but this has moved the dial in a way I have never seen in over 20 years of working in cervical screening, and definitely, I think, is going to be critical in achieving the coverage and acceptability that we need in Malaysia, but also globally.
And as an oncologist, we've never been able to say that we can eliminate a cancer. We make big hoo-has, we have big media publicity when we find a medication that can improve, say, the survival by 20% at great cost, at a lot of expenses. We say, let's make this drug available to everybody, but maybe more than 1 million or 2 million ringgit that doesn't actually translate to increased survival. But here we have a simple intervention. It's not sexy, but it's an intervention that if you do it early enough, we eliminate a cancer. That's a very powerful message that we need to get across.
I've always spoken about using the words treatment and cure in cancer very carefully. In most cancers, you can't say, I'm going to cure your cancer. That's my personal opinion anyway. I don't know whether you agree with me. But the more appropriate word is treat. Perhaps with cervical cancer, you can actually say, I can cure you. Would you agree?
I would agree. You won't even need to reach the point of having, I've got cancer. You won't need a point of saying, I've got a pre-cancer, because if we do this right, we can prevent that from happening, we can remove it, we can deal with it, we can cure.
And I think one thing that sometimes people don't understand is that with pre-invasive disease and very, very early invasive disease, you're cured with a gynecologic procedure, and the treatments people associate with cancer are not needed, the chemotherapy and the radiotherapy. So we are talking about something that is much more manageable for people.
Correct.
And based on the ladies whom you have screened, Professor Wu, the ones with the pre-cancer lesions, have they been open to treatment?
Not only are they open to, let's talk about those who are initially very open to treatment. We have 30% of them who will say, yes, coming in, do I have an appointment next week? And there's another 30% on the other spectrum where we really invest everything. We make phone calls, we more than 10 phone calls, we WhatsApp them, we have phone conversations with them, and they're still fearful. And I think we need to respect that from whatever perspective they come from, and it may need a little bit more work. But yes, we don't have everyone who agrees to having a treatment done, and that's perhaps the education that we're still lacking in. You know, I have a story of someone who lives in a village, and in that village, anyone who goes to a hospital never comes back alive. And that is very scary for them. So to sort of offer you a screening test where there's a possibility of going to a hospital, it's an extremely scary thing for a woman.
Marion, you spoke about how to go to the government and, appeal for cervical cancer in terms of funding. You're working in Vanuatu and Papua New Guinea. For countries that want to start this process of vaccinating, screening and treating, what will be first steps for them?
So I think for those countries and those governments, they will have their mechanisms for assessing cost effectiveness. And there is modelling support for all countries that is coming from a variety of people working in the field, including from the Daffodil Centre in Australia and some of their colleagues, that will be made available very soon, that will enable a cost effectiveness evaluation, looking at the various choices about what sort of vaccination program to introduce, what sort of screening program to introduce, and what the access to treatment might be. And coming out of this software that's going to be released soon will be cost effectiveness evaluations, time to elimination, return on investment, and those are the metrics that not only governments but advocates need to really drive investment, as you were talking about, into cervical cancer elimination.
I think what's important with all this data is to have an advocate, someone who will fight the case. It can be anyone. It could be a patient, it could be a politician, it could be anybody who has that sort of vision for the country, backed with that data, to go to a government and say, look, this is a really good case investment, this is the information I have, hear me out. And that's a good place to start.
So, Marion, high-income countries, Australia is a high-income country, but why is it no other high-income country has come close to what Australia has actually achieved?
So in the days where cytology was the test, we were amongst the best in the world, but there were others with us. And the reason I think that we did very well is our government, and this was before I came back to Australia from my overseas training, the government had really invested in organising the screening program and had moved away from just doing the test to organising a program. And that came to a very early recognition of the need to regulate the quality of cytology laboratories after some international scandals with low quality cytology. It came to organised health promotion that continued through the years, and also to the establishment of screening registries to really track people through the screening pathway, to send reminders to those who are overdue for follow-up when their screening test was positive. And so those three things have been really, really important in our cytology-based program. And then we had the early decision, although we weren't first in the world to go to HPV primary screening. The Netherlands and I think Turkey beat us to that, but we were early adopters of HPV primary screening. So we built on strong screening program fundamentals with a better test early on, and I think that's why things are going well for us. But I don't want to, I want to be humble about the fact that we've had great support from our government. We haven't experienced the challenges that other countries have. And so we are always learning too. And we also have inequity in Australia, so we have to address that as well.
So, Marion, high-income countries like Australia have invested a lot in this whole initiative of vaccinating, treating, screening and treatment. What about low and medium-income countries? You worked very much with data analysis. We are in Malaysia still trying to get a registry established and going, which, we will have to fall back on when it comes to executing these programs well. How do you suggest low and medium income countries can actually adopt data and analytics when, resources are limited and not always available?
So I think what's important to understand is that there are tools coming that will make it quite simple and straightforward to generate the business case, to generate the total resourcing required, the return on investment. And that will not require a consultant for 6 months or expensive exercises. This is really democratizing cost effectiveness evaluation and making it available to low resource settings. I think all of the countries that are classified as low and middle income will have their primary data populated into the model, and then a variety of different inputs can be put in. Do we vaccinate boys as well as girls? Do we do multi-age catch-up? How often do we screen in a lifetime? Is it twice in a lifetime, or every 10 years, or every 5 years? Those sorts of variables can be put in to generate the resource requirements and the local costs of the tests available to you. So I think it's really important that countries, as you say, have access to these tools to really build the case, because we need to tell stories to be compelling, but it needs to be underpinned with strong data supporting those stories.
And I think in terms of Malaysia, how we've started what the movement, or even the first steps, is really to work with professional societies. We've worked with the Obstetric and Gynecological Society. We're starting to work with the academy, and very important to work with media, whether it's radio or whether it's a newspaper, to generate that interest, and then to work with our women leaders, and in our case, our female members of parliament were very important in bringing the case to be voiced and be discussed at the parliament level. To say women only is a bit unfair, because I remember distinctively having our Deputy Minister of Health hold a swap in Parliament saying, why isn't this available to all our women? And I still have that photo captured. So I do think it needs multi-level advocacy, not just data, but trying to get the voice, to sing it louder, to shout louder, to get this done, because it's something worth doing.
And I think there's an important thing that Rose is doing, and that is by going out there and doing screening and undertaking this model, instead of telling the government how it can work, you're showing them how it can work. Because when you make deep change like this, you get a lot of people saying, but what about this and what about that? And sometimes the only way to overcome that is to demonstrate that yes, it's not perfect, but look at the rates of follow-up that Rose is achieving with these elements. Malaysia, like many countries, highly capable of doing this, and it's a matter of prioritising it. So it's telling the stories, demonstrating or showing that it works, and having the underpinning data and business case. It's got to be multi-pronged, as you say.
It's very scary to make the first step into the unknown. And many people will say, get it perfect first. Line all your ducks up first, then take the first step. But we've learned that sometimes we know that, what's the saying, perfection is the
enemy of
good. And so taking that first step, getting some help along the way is it's courageous. You need to do that, and someone needs to do that. And in my personal experience, there's been very few experts who would say, "Nah, I won't help you." I think if you go to globally, there are enough who are prepared to lend a hand, and I think to reach out to those who are able to, expertise-wise, will be a really good step forward as a start.
And I think we in Australia have got an obligation to help in the region. We've got a responsibility to use what we've learnt from screening over the years to help our neighbours.
And would you like to leave us with a message? I'm going to start with Professor Wu.
I believe we are at a good time in history to be able to make a real change, not just locally, but globally. We should share these lessons and we should make cervical cancer history. It is possible. It is not just an opportunity, it is our responsibility.
Look, I couldn't agree more with what you've just said. We can do this. This is a disease of inequity, and we really need to make these prevention tools available to everyone in the world. And I will just finish by saying this is also a gender issue. We are talking about the health of our sisters, our mothers, our aunties, our daughters, and our governments need to invest in making sure that we can prevent something that's entirely preventable.
Ladies, thank you for joining us. Professor Marion Saville, Executive Director at the Australian Centre for the Prevention of Cervical Cancer, also trustee at the Rose Foundation, and Professor Wu Yin Ling, founding trustee and advisor at the Rose Foundation. Thank you for joining us.